So now we're going to start our last module, which is also an important module, that is disease monitoring and follow-up care in rheumatoid arthritis. So here are our objectives: to explain the importance of close monitoring in routine care of patients with RA, to describe key composite measure and best practice guidelines for monitoring the efficacy and safety of treatments. So to review follow-up care strategies and intervention for improving patients' adherence to treatment, self-efficacy, and satisfaction. And also we will describe our role in providing telephone advice line service, supporting self-management approaches, and nurse clinics. So in this module, we have 3 sessions. The first one is introductions. The second one is monitoring efficacy and safety of treatment. And the third session is follow-up nursing care for the disease. I'm sure you all know very well about the nature of rheumatoid arthritis. But I'm so sorry that I need to repeat it once more in this module, because it is a very important concept. Rheumatoid arthritis is a disease. If it is active and you leave it untreated, and then the patients can develop irreversible joint damage and joint erosion. And it would deeply affect the patient's normal functions and activity. So early and proactive management with rapid disease control are important for improving patients' belief in self-management and disease control. So we need treat-to-target approach once we confirm the patient has rheumatoid arthritis. So with early diagnosis and aggressive treatment, treat-to-target approach allow adequate disease control, prevent joint erosions, and also other complications in rheumatoid arthritis. And we should monitor patient regularly and closely, and also should make a change and adjustment to the treatment according to their disease activity. So we come to the concept of treat-to-target again. So the ideal goal is, of course, disease remissions. That means patient does not show any sign or symptom of disease activity. But for patients with severe disease or long-standing poorly managed rheumatoid arthritis, and low disease activity is still the second best options. So actually there are some studies described about the duration of disease remissions in 2011 and 2012. So it shows just a minority of patients can maintain in sustained remissions. So in one study, less than 3% of the RA patients are disease-free at 2 years. So that means if we want our patient to maintain a long-term disease remissions, then we need to use the T2T management approach. So what is the role in monitoring and follow-up care? So as a nurse, we should ensure that patients are actively engaged and understand the importance of T2T to enable long-term outcomes. Here are some strategies. First, patient education, which is a bread and butter in our daily practice, self-management support, and also emotional support, just like the counseling. So we should conduct long-term and regular monitoring of patients' disease, treatment response, and side effects. So for newly diagnosed or active disease, we should monitor the patient regularly and frequently, like monthly to 6 weekly. So we come to session 2. So in sessions 2, we'll discuss about some important aspect or role of our role in optimizing monitoring so as to ensure efficacy and safety of our treatment. So how to achieve this? Well, we can use some key recognized international protocols and guidelines of treatment management and monitoring. So here I would like to show you several key international medical organizations with relevant recommendations include ACR, APLA, and EULA. So for details of these guidelines, you can discuss with your medical team. But today, I would like to highlight the similarities and differences across these key guidelines. So for monitoring disease activity, these three organizations share a common goal. So let's go through ACR first. ACR is more focused on the laboratory monitoring. So for patients on treatment for less than 3 months, then they need to monitor more frequently, like 2 to 3 weeks. But if on treatment for 3 to 6 months, then the monitoring should go like every 6 to 12 weeks. EULAR and APLA, they recommend to monitor the patient every 1 to 3 months if there is no improvement by 3 months after treatment, and initiation, or if the therapeutic goal is not reached by 6 months, then adjust the treatment regimen. And for APLA, it also recommends that we should use an appropriate and practical standardized tools. That is what we talk about is the health assessment questionnaires and the DAS28 scores. And we will discuss these assessment instruments in the later part of my presentation. So let's look at the monitoring adverse events, contraindication to therapy, drug toxicity, and other warning consideration. For ACR, it highlights the annual TB screening for biologic if there are risk factors for future or ongoing TB exposure. APLA didn't mention anything concerning this, and APLA highlight the safety monitoring for patients on DMARCs. So apart from international guidelines and protocols, there are still some recommendations from other regions of the Asia Pacific. So today you're now in Hong Kong, so I would like to highlight our local recommendations. The Hong Kong Society of Rheumatology in year 2011 published a management of RA consensus recommendations. So it highlights 4 major items. Firstly is to assess the disease activity with VAS score using 28 joint counts at a regular interval, preferably during each clinic visit. And it also recommends to regular assess the extent of patient disability and functional capability with the HAQ and also other outcome measures such as SF36. And we do annual TB testing for patients on biologic if there was exposure to TB or the high risk of transmission is high. And also we recommend regular monitor patients on biologic for side effects, conduct chest X-ray, CBP, liver renal functions, and we will do annual monitoring of the lipid profile. So what about Japan? The Japan College of Rheumatology did publish 2 guidelines on the use of biologic, namely etanercept and tocilizumab in year 2006 and year 2009 respectively. And it highlights the screening before the treatment and also the monitoring of the adverse event, the potential adverse event of these 2 biologics. So I think after reviewing a number of guidelines and protocols, you may appreciate there are some difference across these guidelines. So why is that? It may due to practical management issues on the ground, cost pressures, and also there are some differences in opinions. So as a nurse, we should understand this recommendation and recognize the challenge, but we still need to adhere to these guidelines that apply. So we go to disease activity monitoring. So how can we check whether a treatment is working or not? So we should we can achieve by doing the following 4 items. First, disease assessment of tender and swollen joint. Second is the laboratory measure, ESR and CRP. And the third one is a radiological investigation like X-ray and ultrasound. And lastly is a patient-reported outcome. So I would like to go through this one by one with you. So for joint count, according to the American College of Rheumatology, EULAR and Outcome Measures in Rheumatology Initiative, disease remission is defined as joint count less or equal to 1, and swollen joint count less or equal to 1. So, and for tender and swollen joint count, we use 28 joint count, and we also look for active joints in the feet, at the MTPs joints, and also the ankles. Laboratory measures, disease remissions is defined as CRP less than 10 milligram per liters. And CRP is preferred measures of RA disease activity as the test is widely standardized. But sometimes we also check ESR, and for ESR, the normal reading for men is less than 20 millimeter per hour, and for women is less than 30 millimeter per hour. Actually, the ESR is less expensive than CRP, but actually many hospitals and countries do both tests. Well, in Hong Kong, we do both tests in most of the unit, rheumatology unit. So how to regular monitor ESR and CRP? So for every cases, we do a baseline values before starting the treatments, but we have to alert that inflammations or infections would normally increase CRP level and ESR level. So then after checking the baseline, we start the treatment for patients, and we conduct routine lab tests according to clinical protocols. If there are abnormal results, we should inform the physician before administering medication. So X-ray. X-ray is still a common test in most of the rheumatology units because it is less expensive, and it is practical to undertake as in the first consultations. And this is also a part of the diagnostic criteria outlined it. But it also has its limitation, that it is not sensitive to identify early changes in disease, such as bone erosions and edema of soft tissues, which is very important for T2T approach. So that means we need to look for some other more sensitive imaging modality, such as ultrasound and MRI. So ultrasound is in time will replace the other commonly used investigation modality, simply because it is more valid, reliable, reproducible, and sensitive to disease change than X-ray. But for doing ultrasound, we do have challenges here, because it is more, it requires more hands-on experience, and for some countries, if there will be some barriers because there are lack of trainings, and for equipment for them, the ultrasound equipment is not easy accessible for them. So then for MRI, it can detect the inflammatory and destructive changes in joint earlier than X-ray and ultrasound. But the limitation is the MRI is more expensive than X-ray and ultrasound. So we come to patient-reported outcomes. Actually, we can ask the patient to provide us some information on their health, disease symptoms, their ability to perform daily activities, and whether they are satisfied with our treatments and their quality of life. So today, I would like to introduce two questionnaires for patient reporting. The first one is a health assessment questionnaires, HAQ, and the other one is the EuroQOL 5-dimension questionnaires. So health assessment questionnaires, I think most of you must very familiar with this questionnaire, because this is one of the first patient-reported questionnaires, and this is used in various patient populations and translated into 60 different languages and updates for minor cultural changes. And it assess how patients conduct activities in 8 categories, such as dressing, rising, eating, walking, hygiene, reach, grip, and other usual activities. And you can also find whether the patient can perform these tasks with the help of an aid, device, or other physical assistant. So how to interpret HAC? Actually, there are 20 items of the 8 categories which represent a comprehensive a set of functions, activities. So for each questions, there are several, for each categories, there are several questions under each categories, and the patient has to score each of the questions that represent how difficult they can perform that particular task. So so for the category scores, the higher the score, that means the patient is more disabled. Then the score is like that: is 0 represent without any difficulties, 1 represent with some difficulties, 2 with much difficulties, and 3 is unable to do. But for the use of device, ACE and with physical assistance, so for the score of 1 to 0 will increase to 2. If the score is already the patient score at 3, then it remains unchanged, the score. So after this, we will we will sum up and give an average to the overall HAC disability index scores, and ranging from 0 to 3, that is mild difficulty to very severe disability. So how about EQ5D? EQ5D is widely used to evaluate quality of life for RA and other chronic disease as well. And it focuses on 5 domains: mobility, self-care, usual activities, pain and discomfort, anxiety, and depression. So EQ5D is a 2-part instrument. And the first part, the patient has to report their problem in performing the activities in these 5 dimensions. So, and then the 5 dimension is further divided into 3 levels of severity, corresponding to 1, no problem, 2, some problem, and 3, extreme problem. So, so in the end, then by combining one level of each of these 5 dimensions, and we'll give a score as 3. That means 243 unique health status, or you can convert the score to EQ5D index and utility score at 0 for deaf to 1 perfect health. And then in the second part of these instruments, you can see that the patient need to score a visual analog scales, and they should score on these vertical lines and indicate their perceived health status. The range from 0 to 100. 0 represent worst imageable health status, and 100 is represent the best imageable health status. So I would like to share a bit of these questionnaires, because you can see that when compare HAC, EQ5D is the scoring and calculation is more complicated. And actually in clinical practice, well, in Hong Kong, we use HAC more common in our clinical units. And for EQ5D, it is still a very sensitive patient report outcome measures, but it is more common to be used in research basis. So actually, there are numbers of clinical evaluations, outcome measures for you to choose. So you can choose anyone that you like in your own practice. So apart from patient report outcomes, some patients will report the physical symptoms to us. So we need to alert, and there are some common symptoms where we should look out for during clinic visit, like usual bleeding and bruisings, like after the patients having DMARDs and biologics. And is there any sign and symptom of infections like fever, headache, any allergic reactions like rashes, and any GI upsets and chest symptoms after all these therapy, and we should look out for. So we come to laboratory assessment. These are 3 main laboratory tests we should do for monitoring of management. That is complete blood picture, liver function, and renal function. So this is the normal range of values of the blood component, red blood cell, white blood cell, and platelets, and we should alert for the normal range. So just like ESR and CRP, before we start the treatment for patient, we should check the baseline CBP for patients, because patients with RA may represent anemia, which is a normochromic, normocytic anemia, and may have increased amount of platelet. As some therapies can cause bone marrow suppressions, we should also watch out for pancytopenia, neutropenia, anemia, leukopenia, and thrombocytopenias. So after we start the treatments, we should conduct regular monitoring of these bloods, and if there is any abnormalities, we should inform our physicians before we go into administering the medication. So same with the liver functions. So remember to check your baseline liver functions. And these values are important to determine which treatment can be safely used in the patient. Hepatitis B and C tests should also be conducted with medication that could be liver toxic. And monitor liver function closely, as there are a number of therapies that can cause increase in liver functions, namely the DMARDs and biologic therapy. So patients start treatment, you should regular monitor their blood, and then if there is any abnormalities, you should give a shout to your physician. Renal functions, because some therapies may lead to renal impairment, so we may need to adjust in patients with impaired renal functions. So just as same as before, check baseline, and then after treatment, you should closely monitor renal functions, and if there is any abnormalities, give a shout to your physician. So we come to treatment, how to monitor safely of RA treatment. So firstly, we'd like to share with you the NSAIDs. There are two kinds of NSAIDs, non-selectives. One includes like ibuprofen, meloxicam, and naproxen. So what kind of considerations we should look for before we start the treatment? We should consider it carefully for elderly patients. Those may have renal impairment or a history of GI ulcerations. And we should monitor blood pressure regularly, because if we, for long-term use of NSAID, we raise the blood pressure a bit. Renal function should be monitored. And we also, NSAID will cause increase in liver enzyme and should be discontinued when we observe any derange of liver functions. But we should avoid the use in patients with impaired hepatic functions. And due to increased bleeding tendency, we should avoid combining with an anticoagulant or antiplatelet medication. So for selective COX-2 inhibitors like Celebrex, it would increase liver enzyme, but it is reversible when the drug is discontinued. And when compared to the traditional NSAID, it is less harmful to the GI tract. How about steroid? There are different types of steroids, and we should monitor patient blood pressures, body weight, urinary glucose, blood glucose, and or HbA1c, bone mineral density scans. We should check it for annual checking, or equivalent every year, or every second year, depending on the local recommendation. Long-term high-dose steroid may lead to osteoporosis, cardiovascular disease, cataract, weight gain, GI ulceration, and elevated blood glucose level. And the higher the dose, the duration of glucose treatment, the higher the risk of all these adverse events. How about DMARDs? The commonly used ones is methotrexate. So we need, before we start the treatment, we do lab monitoring, especially liver functions and blood counts. We should consider it used carefully in patients with impaired hepatic functions or liver disease. And we should monitor closely with the liver functions. And dose modification may be necessary in those with renal impairments, and it may cause chest symptoms, just like interstitial lung disease, pneumonitis, and But the most common side effect reported was still the GI, on the GI side, which is nausea and fatigue. And it may also cause anemia due to bone marrow suppressions. Less common side effects include blood count abnormalities, and we should avoid using patients who are pregnant and who are going to start their family. So levodopa, most common side effects include diarrhea, GI upsets, liver function should be monitored, and we should avoid to use for patients who want to start their families. And for side effects, if there are any side effects, we should wash out these drugs. But the drug takes quite a long time to be excreted. It takes up to 2 years' time. So we should alert for this. So sulfasalazine, just like methotrexate and levodopa, regular lab monitoring of CBP is important. Some common side effects include GI upset, nausea, vomiting, diarrhea, and some allergic reactions like skin rash. And we should alert patient to drink more fluid and prevent kidney stone formations. And we should remind the patient do not crush the medications, and it may cause orange-yellow discolorations of the urine or skins. For hydroxychloroquine, laboratory monitorings include CBP, and most patients tolerate this medication well, but some may report diarrhea, skin rashes, and patients should be advised to take the medication with food or milk if GI upset occurred. And this drug is actually more mild than other DMARDs. It is not liver toxic. And drug modification may be necessary for patients with renal impairment. So annual eye examinations are recommended because there's a risk of maculopathy. So we go to biologic DMARDs. So the JAK2 inhibitors, tofacitinib, we should avoid use in patients with hepatic impairment, low white cell count, or with hemoglobin level less than 9. We should monitor the cholesterol level and liver enzyme, monitor for all infections and latent TB and hepatitis B. So other categories, anti-tumor necrosis factors, the monitoring is just the same as JAK2. We look for serious infections, TB, and reactivation of hepatitis B. IL-6 inhibitors, we monitor cholesterol, liver enzyme, white cell count, and any infections we should look for. And another special symptoms we should look for is the abdominal symptoms, because there are reported case of bowel perforations when using tocilizumab. So B-cell depleting therapies, rituximab, we should monitor serious infections, TB, and reactivation of hepatitis B. So we come to the end of these sections. So I will give you key to takeaways. Patients with RA should be frequently monitored, and many of them do not achieve remission despite improved treatment options. And according to the international guidelines, APSLA and EULAR, disease activity should be monitored every 1 to 3 months, while ACR recommend monitoring every 2 to 4 weeks for the first 3 months of treatment initiation. And the safety of treatment use should also be monitored. We should regularly monitor the blood results, monitor if there is any bone marrow suppressions, and you can review the symptoms for patient, like see if the patient has any bruising or bleeding, and assess for signs and symptoms of infections. And we also need to monitor if there is skin reactions, liver and renal side effects. And the effectiveness of the treatments can be determined by 4 important items, namely joint count, acute phase reactant, that is ESR and CRP, patient-reported outcomes, and imaging modalities. And patient-reported outcome tools include HAQ and EQ5D and other clinical evaluation questionnaires you can apply it in your daily practice. So session 3. In these sessions, we will talk about how to follow up a patient in a personalized way, and we'll consider some elements like psychological and social aspect, which will impact the patient's perspective on their disease control, quality of life, and pain. So there are some factors affecting patients' treatment adherence, and all these points can lead to patients stopping treatments or using them irregularly. And I'm sure you all know this very well, because you may encounter this problem in your daily practice. If the patient do not know much about the disease and treatment, they would want to stop the treatment. If the patient believes that treatment is not effective, and if they feel that they are not in control of their treatment regimen, and if they have fear of the adverse event, and also one thing we should highlight, poor communications with healthcare professional is also one of the factors can affect the patient's treatment adherence, and also lack of support from family and friends. So in this case, support from healthcare professionals, particularly nurses, are very important to improve treatment adherence. Nurses has a very important and special role, because we spend more time with a patient when compared to the physicians. So we have a privilege in this aspect. And we should encourage a patient and family-centered treatment approach by adopting good verbal communication, good nonverbal communication, emotion engagement, and humor. And I would like to go through this one by one. So verbal communications, actually it can empower patients to make informed decisions by improved communication with nurses, patients, and their families. But it is not difficult to do, because it does not require too much additional time or resources. So for non-verbal communication, we should assure patients and make them feel cared for. So nurses who are more available and willing to listen to patients, and they will appreciate us more. And the thing is, this does not require too much additional time or resources in your clinic time. How about emotional engagement? With emotional engagement, we improve patients' ability to understand and effectively cope with their illness. So increased and structured emotional engagement between nurse and the patients is very important. And it can help to increase the rapport between nurses and patients. So, sense of humor. Do you have sense of humor? Will you apply this in your clinic or inpatient settings? So this helps patients relax and forget their troubles, so they can better concentrate on understanding treatment. So more friendlier nurses who integrate humor when interact with patients can make the patients more easy and more comfortable to share their problems and worries with you. So we come to personalized follow-up care. Firstly, patient education is very important. Patient needs reassurance, and if they are more informed, they will be more competent and better able to manage his or her own disease. And nurses is playing an important role in improving knowledge on treatment and disease. And the other thing is self-management support as one of the important thing to personalize our follow-up care. We should motivate our patients and equip them with self-management skills, so they can feel that they have more control over this disease and be empowered. Lastly, emotional support. We should regular monitoring their emotion changes and manage their psychosocial issues. There are some strategies to provide personalized care. First of all, we have nurse clinics. Well, in Hong Kong, we have numbers of rheumatology nurse clinics in different hospitals. So what are we doing is we monitor patients' response to their drugs, monitor the disease activity and the safety profiles of the treatments, and also we provide patient educations and determine whether the patient needs to refer to other healthcare professionals like physiotherapists, occupational therapists, podiatrists. Other strategies include telephone advice line service. It enables patients to contact us to discuss how to manage disease symptoms and any issue they have with treatment. And it also enables other members of the team caring for the patient to contact each other for advice. Here's other key takeaways. Our structured follow-up care includes patient education, self-management support, and emotional support. And we have a very important role in increasing patients' knowledge on disease and treatment. And we can help patients to manage their own disease, and we can provide patients with emotional support. Nurse clinic is very common for disease monitoring, drug monitoring, and continued management of the patients with rheumatoid arthritis. And telephone advices and other continued support for our patients. We can enable patients to contact us and may help the patient have more control, and we can empower the patient more during the patient journey. So a personalized structured follow-up care includes patient education. Oh, sorry. So that it comes the end of these modules, and we will start our group training workshop, the last workshop. So here is the grouping of the workshop. So as before, we have a 45 minutes case presentation and discussions. And then we will have a group presentation, and then we'll complete the post-training knowledge assessment. So here is the case for the Module 3. Mr. T, 42-year-old Indonesian man, and he presents, on presentation, he has extreme pain in his fingers and wrists, and then referred to rheumatologist. The nurse took a complete history, including his medical and surgical history, and his family and work lives. So Mr. T is an independent handyman who does home repair and renovation. He's married with 3 sons. Over the last 6 months, Mr. T began noticing stiffness in both hands and wrists in the morning that lasts longer and longer. And he started to take painkiller and help him get through his days. But the pain worsened in the past weeks and causing him to stop work and preventing him from doing his usual activities. So with his wife's insistence, he visited the GP. So after conducting physical examinations and running a few tests, the GP referred Mr. T to a rheumatologist. So here is a patient's assessment. Many of joints examined were under tender and swollen, and blood tests were conducted and reviewed with positive rheumatoid factors, positive anti-CCT antibodies, raised ESR and CRP. So this is the X-ray showing erosion in MCP and PIP joints. So here we come to the first set of questions. Ms. T was diagnosed with established RA. Symptoms were present for more than 6 months. And the question is, once RA diagnosis is confirmed, the T2T approach should be triggered. In your practice setting, what roles do nurses play in achieving this goals? Then we'll start our group discussions, and we'll go through the story bit by bit.